Okay, so my name is Amanda Galicchio. I am one of the infection preventionists here at Riverview. I have a nursing background with a master's in nursing. Prior to doing this, I worked on the unit as a floor nurse, so I was able to bring my experience with that into infection prevention, which was helpful. Wendy Mahalik is our director, so she is the one who we go to with all of our concerns. She's been here for a while, so she has a lot of good knowledge and is a great resource. Stephanie Garcia is our other IP. She is the only one of us that actually is not a nurse. She has a master's or a background in public health and in microbiology. So what's really great with her is microbiology plays a big part with infection prevention when we're looking over our cultures. So she's extremely helpful and has also been a great resource. Okay, so infection control prevention, what it is that we actually do. So we do a lot of surveillance activities, including daily rounding on the units, as well as the other ancillary departments in the hospital. Our main focus is our central lines and our indwelling urinary catheters. We do a lot of rounding on that to check for compliance. And when we're doing our rounding, we will speak with you directly if there's any findings that we have so that we can address them in real time. And we also do reach out to the educators and to the leaders to let them know the findings so that they can be followed up on. We also do daily reviews of all our positive cultures. Any kind of culture that is drawn or collected on a patient, if it comes back positive, gets sent to our database that we review. And the reason this is important is because we want to determine if this is something that is hospital acquired or if this is something that was community onset. If it's something that is hospital acquired, then that means we have to delve more into it and really investigate into it. We also do electronic reporting at the local, state, and national levels. We reach out to our health department if there are certain things that come up that have to get flagged and reported. It's also a great way to keep track of what's been going on, especially with COVID. We were doing a lot of reporting with that to determine where we were at and how many cases there were. So it's a lot of hand in hand with the health departments. We also do a lot of hand hygiene observations. We round throughout the hospital to make sure that we're being compliant. We are having changes to our hand hygiene observations where that'll be updated as we go, and education on that will be sent out as it happens. We also do a lot of patient and family education. If there's a patient who has a new infection and they have to be put on isolation, we want to make sure we're providing them with that education so that they understand why they see people coming in with gowns and gloves and masks or face shields. And we also want to make sure that they understand what it is that they now have and what is being done to help. We also do continuing education on infection prevention related subjects. There's always something going on that's new or changing. So that education gets brought out, and then we want to push that education out to everyone else so that they understand what's going on. So why do we do surveillance? Because an infection can impair a patient's recovery. It can increase their length of stay. It can increase healthcare costs. We all know that antibiotics can be very expensive. So this is something that can cause a lot of issues. It also increases the likelihood for a hospital readmission. We tend to see a lot of patients come back because of an infection that's getting worse, or the antibiotics are not effective anymore, so they're being readmitted. And ultimately, it can lead to death. I will say one of the ones that you really have to be careful with is MRSA. Staph aureus is something that is all on our skin, but the problem is once it gets into our body and into our bloodstream, it can cause death, especially if it's not caught quickly and treated quickly. So this is why we really have to be careful with everything that we do and make sure we're doing everything properly and cleaning everything. So our causative agents, we all know that there's viruses, bacteria, and fungus out in the world. Some common healthcare acquired pathogens that we deal with, MRSA, our ESBLs, our C. diffs, CRE, MDRO, VRE, and there are tons and tons of other ones out there. But these are the really common ones that we see a lot within the hospital. So our causes of antibiotic resistance, overprescribing of antibiotics is something that we still have to worry about and make sure that it's not occurring. This is why it's really important if we have a patient who comes back with a pathogen, a bacteria, that we get our infectious disease doctors involved. They will make sure that they look at the cultures and the susceptibility to make sure that the patient is put on the proper antibiotics and that we're not just doing a lot of broad spectrum, which can be an issue. We also want to make sure that patients are taking their antibiotics as prescribed. If they're not doing that, it leads to resistance. Where this is really important is if your patient's being discharged home with an antibiotic, it's important to make sure that you explain to them that they should complete the full course of the antibiotic unless their provider tells them not to. You don't want them to abruptly stop because that's how the bacteria builds up a resistance, and then that antibiotic that once worked will probably not work anymore. Unnecessary antibiotic use in agriculture is another reason there might be resistance. I feel like we're seeing this stray away a little bit. We see a lot of advertisements about them not using antibiotic use and free range. So we're starting to see this go down, but it's still something that we need to consider. Our poor infection control in the hospitals and clinics and poor hand hygiene and sanitation practices are two things that are extremely important when it comes to resistance. If we're not cleaning things properly, not washing our hands, not properly doing, the practices that we should be doing, this is going to lead to a huge resistance because these bacteria learn how to adjust and change. So we have to make sure that we're being careful. Also, lack of rapid laboratory tests. Unfortunately, you can't rush the growth of a culture. So there's just some things that are really unpreventable. But in other cases, there are things that we should look into that might need attention if labs are taking too long to come back. So we really do have to make sure that we're keeping on top of our cultures. So our chain of infection is something that we talk about in nursing school very frequently. You have to have your causative agent. Then there has to be the reservoir where it dwells. You have to have your portal of exit, so sneezing, coughing, anything that allows that bacteria to get out. Then you have your mode of transmission. If somebody coughs or sneezes on their hand, they don't properly wash their hands and then they touch something or touch somebody else. So now it's transmitted. Then your portal of entry. So if that's on your hands or anything else, and then you touch, say, your face or you touch anything else, well, now we have the portal of entry. And it's where there's a mucosal membrane, especially, is a very easy entry point. And then the last part is the susceptible host, which we say everybody who's in the hospital is considered susceptible, or else they wouldn't be here in the hospital. So our reservoir or home for pathogens that we typically see in a patient room, pretty much anything in that room that the nurse, the tech, the patient, the doctors, anything that anybody can touch is really going to be a reservoir for the pathogens to live. So you really want to watch those high touch areas especially and make sure they're being cleaned. So like your IV poles, your bed rails, the call bells, the curtains, those bedside tables, any kind of handles that they're touching, like if they're in the bathroom, the light switches, so pretty much anything. So that's why we really have to make sure that we're cleaning everything properly and we're cleaning our hands properly. So breaking the chain of infection, the number one way to do that is through hand hygiene. We also want to make sure we have our clean environment and clean equipment. The transmission-based precautions, you always have to follow your standard precautions, which is where you're going to be washing your hands, using your gloves, and then washing your hands when you're done. And then if you have other isolations, then you need to follow the protocol for those, which we'll go over later. You also want to make sure you're monitoring for your symptoms of infection and reporting them early. The earlier that we catch and report this, the better we have at treating it and making sure that we're catching it quickly so that it doesn't get worse or that the antibiotics are no longer effective. We also want to make sure we're treating infection, not colonization or contamination, which again is where our doctors, like our ID docs, come into play because they're really looking at those cultures to determine if it's an active infection so that they know how to treat it. Also, the appropriate antibiotic utilization. Again, the doctor's looking at the susceptibility reports. We always want to get our invasive devices out as soon as possible. This is something that we go over with you guys when we're doing our rounding because we want to make sure we're getting them out as quickly as possible. And we always want to advocate for immunizations. So these are some of the PDI wipes that you'll see throughout the hospital. What's really important to remember is that the numbers that you see on the containers are the treatment time. So what that means is it's the amount of time, not that you have to sit there and rub it and clean it, but it's the amount of time that the surface has to be left undisturbed after you wipe it. So you need to make sure you wipe everything down and let it dry on its own. Don't go over it with another paper towel to wipe it off because then it's not doing what it's supposed to be doing. So your purple tops are your 2 minutes. Those are for your hard surfaces, the bed table, the BP cuffs, thermometers, the AccuCheck machines, all your non-electrical equipment. Then your 4 minutes are your bleach wipes. Your bleach wipes are going to be for all of your enhanced contact rooms. So that's like your C. diff patients, Candida auris patients. So anytime you see any of those signs, which we'll go over in a little bit, any of those signs that are on the door, that's what you're going to use your bleach wipes for. Your 3 minute times are your gray tops, and that's for your electrical equipment. So like your monitors, your EKG machines. Okay, so this is just a quick video. I'm not going to go through it on here because it's kind of basically describing that hand hygiene is extremely important. We have to wash our hands sometimes hundreds of times a day, and healthcare providers and healthcare workers actually sometimes don't wash their hands the way that they're supposed to. They found that they do it less than half of the time that they should. So what this is doing is it's increasing the risk for the patients to get infections, to become very sick, and it ultimately can lead to death for them. So that's why we really need to make sure that we are cleaning our hands the way we're supposed to be, and that we're constantly on top of that, doing it in and out, making sure between any kind of procedure that you're doing, it's extremely important to make sure that we're washing our hands. It doesn't take that long to sit there and use that sanitizer, and make sure you rub your hands clean. So just make sure that we're really doing that frequently. So our types of hospital-acquired infections that we deal with, we have SSIs, or our surgical site infections. We have our CAUTI, which is our catheter-associated urinary tract infection. Our CLABSI, which is our central line-associated bloodstream infection. Our MRSA, which is our methicillin-resistant Staph aureus. And then our C. diff. C. diff, what's really important with it is anything from day 4 and on is considered hospital acquired. If you have a patient who's having bowel movements and loose stool, and you collect a C. diff on day 1 of their admission to an inpatient unit through day 3, and it comes back positive, then it's considered community onset. So that's where there's the big difference with that. Well, all of our other infections, they start from the moment they come into the hospital. So you have the 2 days to determine if they have that infection to say that it's community onset. After that, it would be hospital acquired. So that's why we need to really be sending our collections and our labs as soon as we can to make sure that we're catching them within their window if they do have that infection. So our invasive devices, we always want to advocate to get them out when they're no longer necessary. The lines that you'll see are indwelling urinary catheters, or as people like to call them, the Foleys. We also have our PICC lines, our triple lumen catheters. For our ports, we want to get them deaccessed, so that's removing of that needle. And then our dialysis catheters, we have our temporary non-tunneled lines, which we want to remove when they're no longer needed. So our clinical indications for indwelling urinary catheters, some of the things that we see, the acute urinary retention is a extremely common one that we see. What I will say about this is please make sure you're following the algorithm first before you're inserting an IUC. So you want to make sure you're bladder scanning. If the patient has over a certain amount within the bladder, then we want to do straight cathing first. We don't want to go right to a Foley catheter. We want to make sure that we're doing that straight cathing and bladder scanning. If it comes to it that they're still retaining, you've bladder scanned and straight cathed a few times, and they're still retaining, then they might need the Foley catheter. But what I recommend is to make sure you let the doctor know about a urology consult so that they can be followed to see if there's something else that's going on or if they need a medication added. Another common one is to improve comfort for end-of-life care. We see this with our hospice patients. This is just to really help improve that end of life. We don't want to have to cause any more discomfort for them. So this is something that they commonly will do, is insert a catheter. Another reason is for critically ill and need for strict INO monitoring. We see this a lot with our ICU patients. They tend to be on a lot of drips. There's always a lot going on. So they want to monitor their outputs. So they will have a catheter in place. For a patient in the ICU, we really do want to try to get that catheter out if it's only for strict INO as soon as possible, because we want to make sure that we're not leading to any other infections. Then there's also select surgical procedures, or GU or colorectal surgeries. They tend to have catheters in after those kind of procedures. The goal is to get them out post-op day 1. So if we see that that catheter is still in, we will follow up to see what the surgeon has said, and we will try to get more information to see if we can get that catheter out. Sometimes the surgeons want them to be left in. As long as there's documentation from them and they're showing that they want it in place and there's the active order, then that is fine. Another indication is to assist in healing open sacral or perineal wounds. If a patient is incontinent and they have like a stage 3 or a stage 4, that urine on those wounds is just going to make them so much worse. So a lot of the times we'll see that they'll ask to put a catheter in to assist with the healing of the wounds. The need for intraoperative monitoring during surgery should only be used for patients who are in the OR. We do not want to see this indication if they're on an inpatient unit. So if that is still in place and we're seeing that as the documented indication, we will ask you to follow up to see if that catheter truly does still need to be in, or if we can get it removed and try a different alternative. Prolonged immobilization is another reason. If our patients have fractures, we see this a lot because they're unable to turn or move, so they'll use a catheter. But once again, if they go for surgery to have that repaired, we want to try to make sure that we're getting the catheters out as soon as we can. We never want to use them for incontinence or for convenience. There's always alternatives that we can try. So for our CAUTI prevention, you want to make sure you're assessing every shift for the ongoing need for the IUC, and you do want to make sure that you're documenting it every shift into the chart. So with EPIC training, they'll go over where everything should be documented, but we do want to make sure that that's getting done every shift. Always consider your alternatives, which we'll go over. We always want to make sure doing appropriate peri-care with our Provone wipes. So you want to make sure that that's being done at least once a shift, and it should be documented in the hygiene section, which again, they'll go over with EPIC. It needs to be done by either the nurse or the tech, but we just have to make sure that we're doing it and that we're documenting it properly. Please also make sure we're not throwing any of our wipes into the toilets. They all have to go into the garbage. We want to make sure we also keep the drainage bag and tubing below the level of the bladder and off the floor. We don't want it touching the floor or being above the bladder. If it's above the bladder, it can lead to it backing up into the bladder, which is going to give them an infection. We also want to use our IUC stat lock. So that's the sticker that goes on the leg and holds it into place. And that has to be dated and changed every 7 days. The reason we're really changing it too is because you want to make sure you're rotating the spots that it's on the leg, because it can cause an irritation to one spot. So we do want to make sure we're checking the skin. So that's why we're dating and moving it around. We also want to make sure that we're emptying the drainage bag prior to transport. Sometimes the bag's not hung the right way when it comes to transport, so that can lead to it backflowing again. So you always want to make sure you're emptying it so that it's not filling up too much and risking the patient getting any kind of bacteria. So the alternatives that we do have, again, intermittent catheterization, make sure we're doing our bladder scanning to determine if they're retention. If they have the retention, then we want a straight cath first. There's also external caths. So the Texas caths, which is that picture at the top, that's for our males. So if they are incontinent, you can always use that. It also helps to give you an output measurement. Programmed toileting is also very important, making sure that you're consistently going in with the patient, checking if they have to get up and go to the bathroom. Facilitating that sometimes helps them go to the bathroom, so you won't have to worry that there's an issue going on. We also have the PureWick, which is the picture at the bottom. What's great about that is it's a flexible piece that goes in between the labia for the females. It attaches to tubing, which attaches to a suction. So it pulls the urine right into the canister. So what's great is if you have a patient who maybe is incontinent, where you used to not be able to really document their output too much, because if they wet the pads, it's hard to tell how much the output was. This is great because you can measure it. So it kind of has two benefits there. It also makes it more comfortable for the patient, where they don't have to maybe be changed as frequently. You also want to make sure you're following the nurse-driven removal protocol and the algorithms to determine that we're taking the necessary steps to get them out as soon as possible, and that we're not jumping right to inserting a catheter. So our clinical indications for our central lines, inadequate peripheral venous access is one that we see. If you have a patient who is really hard to get an IV on, you've reached out to your other resources like another nurse, your leader, radiology to try to get another line. And if they really can't get one, then they might have to insert a central line. Also, peripherally incompatible infusions is another reason why the line might be inserted. One I will say is like our TPNs, they really shouldn't be run for long term through a peripheral line. So the patient might need a central line in order for that to be done if they're going to be on that long term. Also, a lot of our patients in the ICU, if they're on a lot of medications for like sedation, they really should be running those through central lines as well. So they usually typically always have a central line. There are two different types. There's tunneled versus non-tunneled. So if you can see on the pictures, it's just determining where it's going in and where it's ending. So our CLABSI prevention strategy, always make sure you're taking great care of the insertion site. That's going to be one of the main things that we look at as well. So that nice little patch that we have currently is our bio patch. Again, we'll be seeing a transition, but right now we have the bio patch. So that's that nice little blue circle there. It has chlorhexidine on it, so it's keeping the area clean. What's important with it is the little slit that's on the bio patch. You want to make sure that that opens and goes around the actual tubing. So you should see it completely around the site and on the area where the line goes in. You don't want it on top of it, on the side of it. Also, please make sure the blue side faces up because that's the side that doesn't have the medication on it. The dressing and the bio patch do have to get changed every 7 days and as needed if they become soiled, wet, or peeling off. So this is all stuff that we look at and we will let you know if there's something that we identify that needs to be addressed. We also are using our dual caps or our Tegos for our dialysis lines. So your Tego caps are those little white caps that you see. Those are for your dialysis. And then your dual caps are the dark blue and light blue. The light blue goes on every single port access on any IV tubing or at the end of every lumen for a line. Those also go on all of our peripheral IVs, and every single person who has IV tubing has those caps. That's not only central line specific. So everyone should have those. The dark blue are the ones that go on the end of the IV tubing. So if the patient gets disconnected for any reason, those caps should be put on the ends. The caps are supposed to be changed every 96 hours, but the best practice to do is if you take it off for any reason, discard it and put a new one on. So you'll be changing them more frequently, but it's the best way to make sure that those caps are being changed appropriately. Your chlorhexidine bathing, so that's that maroon package that you see in the picture. So those are our Sage wipes. The bath should be done once a day for all of our patients who have central lines, all of our ICU patients, all of our patients on 3 East, and all the MSK patients who are in the hospital should have a CHG bath done. The product is not to be used on your face. That you have to use soap and water for. And make sure that all of these are getting disposed of in the garbage. Do not flush them. And this has to be documented for completion as well in the hygiene section. So you'll go over that again once you have your EPIC training. They'll show you where to document, but make sure that you're documenting that you're completing it. For our PICC lines, you always want to use your securement device. So that's that picture at the top that helps the line to stay in place to ensure that it's not moving around or becoming dislodged. That also has to get changed out when the dressing gets changed. And then again, we always want to make sure we remove the lines when they're no longer indicated or necessary. Okay, so for our C. diff patient, so you have a patient who's having diarrhea on the day of admission that they come to your inpatient unit. So day 1 to day 3, you can send your C. diff sample as a protocol order. So when you put in the order for a rule out C. diff to send a sample, you're going to get the information on the left, which is kind of like hard stops. Even if you answer yes to any of them, it doesn't mean that you can't send the sample. The reason this is here is to kind of get you thinking if there's something else that can be causing the patient to have diarrhea. So it asks about laxatives in the last 48 hours, oral contrast in the last 48 hours, tube feedings, or the colectomy in the previous 48 hours. These are all things that can actually cause a patient to have diarrhea. So they want to make you think what else could be going on. So the things you want to ask yourself, did you answer yes to any of the questions? You also want to look, was the patient constipated before and now they're having diarrhea? So did you give them something and now it did what it was supposed to be doing? So now they're going to the bathroom more frequently. Also, you want to look at their white blood cell count, if they have a fever or any abdominal pain. If you have any of these where the answers are no, then you might want to sit and think something else could be going on. The common things that we see with C. diff is the WBC count goes up, they tend to have a fever, and they will complain of abdominal pain. So these are kind of your 3 signs that you would say, maybe it is something going on with C. diff, so maybe we should send our sample. Some other important things to remember with this, the orders that are put in will auto cancel if the specimen is not received within 24 hours. So that is something that you really want to pay attention to, because if you have an order that's placed, say, day 1, the patient doesn't go and it cancels itself out. And then like day 2 or 3, well, now they're having diarrhea and you have your sample, but there's no order. You want to make sure that it is in place so that the lab can actually run the sample. So you really do have to keep an eye out for that order to make sure it's there. Stool will not be retested if they've had the positive result in the past 30 days. And if they've tested negative, they will not be retested for 7 days. Okay, so your patient's admitted with an order for a C. diff sample from the emergency department, and they are symptomatic. What do you want to do? So you must collect the sample as soon as possible. So again, anything from day 1, which is the day of admission, to day 3 would be considered community onset. Anything beyond that is considered hospital onset. So if you have a patient who's having diarrhea all of a sudden, symptomatic, and it's like day 4 and beyond, you really want to make sure that you're reaching out to that doctor to let them look at the case to determine if the patient does need that order for C. diff to be sent. After that, day 3, when you start the day 4, don't do it as an order protocol. Reach out to the doctor to let them know what's going on. Some common signs and things that we do see with C. diff. Does the stool completely conform to the shape of the container? So it has to be completely liquid. If it's any other kind, the lab will tell you that it's not an acceptable sample and they will cancel the order. You also want to look, have they had 3 or more liquid stools in the last 24 hours? So the increasing amount of stools, somebody with C. diff, they tend to go a lot. So that's a common sign that you'll see with that as well. Also, do they have any of the risk factors? Risk factors include a recent hospital stay, were they treated with antibiotics in the last 8 to 12 weeks, because it can take that long for it to show. And also, have they recently received chemotherapy? Also, does it have the appearance and or odor that is associated with C. diff? If you've had a patient who's had C. diff, it's something that you cannot forget. The odor that typically comes from a patient with C. diff is very unique. So you'll know it right away once you've had a patient who's had it. Okay, so once C. diff is suspected, we want to make sure that we're isolating the patient. So we will isolate them when they have the rule out, and that isolation will not come off until they've tested negative. And then obviously, if they do test positive, they remain on isolation for their hospitalization stay. We will sometimes look into the cases if they are here for a while. If they have diarrhea that's resolved and it's been greater than 24 hours and they've had treatment, then sometimes we'll evaluate to see if they can come off. But typically we'll see it for the duration of the hospitalization because they tend to continue having diarrhea. So our contact transmission, there's different modes of transmission, indirect and direct. We all know what direct contact is, but indirect is the one that we really have to be careful with, because this is like when our equipment touches the patient and then we don't clean it properly and we go to another patient. So especially like those stethoscopes, if you have them around your neck and you're leaning over and it touches the patient and you don't realize it and you don't clean it, and then you go to the next patient and do the same thing. So we really do have to be careful. Same thing with those carts that you use to take your vital signs. The tubing on them tends to be very long to allow for you to easily take their vital signs, but you have to make sure you're cleaning those carts properly, because that can easily transmit a bacteria from one person to another if you're not cleaning them in between the right way. So the isolation precautions that you'll commonly see throughout the hospital, there's neutropenic, contact, enhanced contact, airborne, droplet, and then our COVID isolations, which are expanded droplet in contact and expanded airborne in contact. So neutropenic precautions is not a true isolation that we ourselves, the infection prevention department, puts into the computer. This is something that the nurses and the doctors will look at, but it is important to know because you occasionally will see these gray signs. So what's great about the signs is it tells you exactly how to wash your hands. It'll tell you what PPE is required, and it also tells you what wipes to use to disinfect everything. So everything you need to know is right on the signs. What's important with the neutropenic is they are people whose immune system is extremely low. So any kind of little tiny bacteria that might not affect us can ultimately kill them. So we really need to be careful with these patients. Always make sure your face masks are worn at all times and appropriately by everyone who goes in and out of that room. And you always want to make sure that you're cleaning your hands and cleaning your equipment properly. So when you'll see this used is if they have a critically low absolute neutrophil count or a critically low white blood cell count. Our contact precautions. So this is our purple sign. So again, it tells you your PPE, which is your gloves, your gowns. You can wash your hands with either soap or water or with the sanitizer, and you're going to use your purple top wipes to clean everything. So examples of when we use this is ESBL, CRE, MGRO, MRSA, and our bed bugs. So for our enhanced contact, which is our brown signs, this we use with basically any of our poop related infections. So the easiest way to remember it, poop, brown. So that's how we associate that to remember that way. Again, look at the sign for what you need to know and what you need to use. So your gloves and your gown. There's two big differences with this enhanced contact isolation. You must use soap and water to wash your hands. You cannot use the alcohol-based cleansers because it's ineffective. So we need to make sure that we're using the soap and water. We also want to make sure that we're disinfecting with our bleach top wipes. You have to use them, or again, the environment will not be cleaned properly. So examples of when we're using this is C. diff, our C. diff rule out, our Candida auris, norovirus, rotavirus. And for all of our isolations, the best practice is what you're going to want to use are going to be the disposable equipment if possible. So like your stethoscopes, your thermometers, this way it's specific to that room. And then once that patient is discharged, it can just be disposed of. So then we have our airborne precautions, which are our blue signs. There's some key differences to note with these as well. You have to use an N95 or a PAPR if you're going into these rooms. So make sure you have the well fitted and you've been tested to know what mask fits you properly. Also, the door must be kept closed at all times because these patients need a negative pressure room. So in order for the negative pressure to work properly, they have to have the closed door. Just make sure if the patient's on airborne that they are in a room that is negative pressure. Not all of the rooms in the hospital are. So we have to make sure we have them in the right area. You're also going to use your gloves and your gown if soiling is likely. You can use soap and water or sanitizer to clean your hands, and you're going to use your purple tops to clean your equipment. So examples of when we use this are chickenpox. Please avoid the patient if you are not immune to chickenpox. Switch out to a different patient. Also herpes zoster, disseminated shingles, measles, and TB. So our droplet precautions are our orange signs. So with these patients, you're going to want to wear the surgical mask that has the shield, or you want to wear goggles. You also want to use your gloves and gown if soiling is likely. And then you want to wash your hands or use sanitizer. And purple tops are going to be what you're used to clean the room, the equipment and the room. Some examples of that we use this for: influenza, meningitis, pertussis, and the rhinoenterovirus. So our transportation of our isolation patients, always make sure you're putting them into a clean gown, put clean linen on the stretcher or on the wheelchair. If the patient has to travel in their bed, so like a lot of our dialysis patients go in the bed, I think some of the surgical cases go down in the bed, you want to make sure that you're cleaning the side rails, the footboard, the headboard with the proper disinfecting wipes. Also make sure that you're wearing your PPE while in the room and assisting the patient, but remove all of your PPE, including your gloves, before you exit the room and wash your hands. You do not want to use any PPE out in the hallway. If the patient is on the droplet airborne neutropenic, you always wanted to place a surgical mask. With everything going on with COVID, everybody has to wear a mask. So the patients, the caregivers, even if the patients are going out into the hallway to walk around, they all have to have a mask in place. Okay, so our COVID-19 symptoms we technically see 2 to 3 days prior. COVID has changed so much, and the types of symptoms that people were having has changed depending on the variant. But some of the common things that we were seeing: fever, chills, cough, shortness of breath or difficulty breathing, nausea, vomiting, diarrhea, fatigue, muscle or body aches, headache, and loss of taste and smell. A lot of the common ones that we see now with these kind of variants and this most recent wave of it has been more with the fatigue, the cold-like symptoms, Whereas within the first wave, it was the shortness of breath and the loss of taste and smell. So it just goes to show that things have changed so much with COVID. So anytime you have a patient who has symptoms, they're going to want to be tested under the pathway to see if it could possibly be COVID. So our testing, again, these are things that are forever changing. So symptomatic versus screening are the different types that we have. If a patient is symptomatic and they're being placed for a rule out, then they should be placed on isolation until the result comes back. If it comes back as negative, then the patient will not need to be on the isolation. But we want to make sure if that's a possibility that we're isolating so that we're keeping everybody safe. For those who are asymptomatic, they'll be placed on a screening test. So no isolation is needed if they're on a screening. The asymptomatic testing we were initially doing, depending on what level the community transmission is, when we're in the red, we're testing 72 hours after their admission. When we drop down below that, that's where that changes. So it's dependent on the community transmission level and where we're at if we're going to be doing the retesting. What will not change is our 5 North Rehab and our inpatient psych are going to be testing their patients on admission, and they get tested twice a week. So if you're on any of those units, you'll see that that will pop up on the work list to be done. Just make sure that we're getting the swabbing so that we can determine that the patients are still asymptomatic and negative. We sometimes see that they'll come in and they'll be negative on admission, and then if we do a rescreen, they pop up. So it sometimes does take that couple of days for them to really show a positive result, especially if they're asymptomatic still. Our exceptions to testing, we do not retest patients if they've been positive within the last 30 days. We see that they can still test positive. We do have some cases where they'll test positive beyond the 30 days, but if this is the case, then we need to consult the doctor to determine if they think that this is a new active infection or if it's just a test that they're going to keep showing positive on. So just make sure you're consulting either the doctor, you can reach out to the ID doctors and have them look at the case. Just make sure that we're evaluating them. So we have our rapid versus our PCR. PCR takes a little longer to come back, but the result is more accurate. So we have our Abbott ID, Cepheid, and our respiratory pathogen panel. The respiratory pathogen panel looks at a variety of respiratory illnesses, whereas the others they'll just look at flu A and B, RSV, and COVID. So the respiratory pathogen looks at all of those, but other ones as well. So again, we have different isolations when it comes to COVID, so we'll go over those. So your expanded droplet and contact precautions are a blue sign. And I will say that both of the isolations, whether they're expanded droplet and contact or expanded airborne and contact, are the same PPE requirements. The reason they're differentiated is it's based on their oxygen requirements, and we don't want to really be mixing our droplets with our airborne patients if we have to cohort. So that's why we look to see what's going on with their oxygen. For your droplets, it's going to be your patients who are on room air or like regular nasal cannula. So you're going to do your hand hygiene before and after. You're going to use your gowns, you're going to use your gloves, your N95, and your eye protection. And then you, again, don't really want to share the equipment if you don't have to, but make sure you disinfect everything between rooms. So you're always going to remove your gown and your gloves before you exit your room and do hand hygiene. And then when you leave the room, that's when you're removing your eyewear and your N95, cleaning your equipment, and then doing your hand hygiene. So again, this is the same PPE requirements for expanded airborne. The expanded airborne and contact sign for COVID is going to be a green sign. So the PPE requirements is dependent again on the community transmission level. So there are different levels that we follow. It can be found under our UPP policy. So if there are changes to the requirements, those get sent out to all of the leaders and all of the team members so that they know where we're at depending on our level. So we have the red level, which is high. We have our orange, which is substantial. There's a green level, which is low. So it all depends on what's going on with the community and what's going to change with that. What's important to know with this is that based on the level you're at, your PPE requirements of what you have to wear may differ a little. So make sure that you're really looking at that and paying close attention to it. They will send out, like I said, they'll send out the emails with the updates, and the leaders should go over with you if there's changes with the PPE. But you can find that under policy stat, under the UPP policy. Okay. So another thing that's really important is our visitors who are here must remain masked at all times. So even if they're in the rooms with the patient, they have to keep their mask on. It's something that they agree to do when they first come into the hospital. I know a lot of the times we'll see that they have their masks down. I've seen where they'll have it down. I'll go into the room, they'll put it on because we walk in, then they'll take them back off. So it's really important to reinforce with them that they have to be masking not only to keep the patient safe, but to keep, if they have a roommate, the roommate safe, the team safe. We've had numerous amount of times where a visitor will come in and the next day they'll tell us they tested positive. So then it's a whole contact tracing to see who possibly was exposed. So please make sure we're reinforcing that masking is important. Also, make sure the PPE that you're using is issued by HMH only. You cannot use your personal PPE, it's not allowed. There are certain alternatives that have been approved by HMH, and that's also under that UPP policy. So if you go to the UPP policy under policy stat, all the way towards the end, you'll see that there's some pre-approved equipment that you can get if you need it. So like the prescription goggles, customized eyewear for like surgical invasive procedures, different things like that with the eyewear especially was the big thing. So you'll see the alternatives that you can use on there. If there's any changes to any policies or anything that changes in terms of PPE, those will be brought to the team members' attention, and the leaders are also made aware. So you can always go to them as a resource, and you can also reach out to us. And then just another cool thing, if you ever find that you need gel, soap, or paper towels, if you dial HAND or 4263 on the phone, it'll send you right to EVS. You can let them know it's empty, and they will come and fill it for you. And then these are just our extensions. You could also dial 0 and ask for infection control or infection prevention, and they will send you to us. So if you have ever any questions, any concerns, please don't hesitate to reach out to us. Thank you.